After I give a talk, Dr. Vogelbaum will give a discussion on lab and clinical research. Dr. Toms will give a discussion on advances in surgery in brain tumor patients. Dr. Crownover will discuss radiation options, and I think he's got his talk filed out here. This year, Dr. Hilden's going to give a talk on pediatric tumors. Dr. Weil is going to give a talk on basic research in proteomics with that. And Gail Dietz is going to give a nursing talk. I think it's kind of interesting because if you look at this, the only person not smiling on here is Gail. And Gail looks like the only one that's really working on here with that, which is probably true with that. So the objectives today are, number one, to help, I think, patients and families better understand brain tumors. Obviously, we'll be discussing things today that are not applicable to your particular tumor, but I think that there'll be something in this for everyone as we go through today. Number two, I think one of the other big things we're going to do today is we're going to share some hope. And I think that all of you are really here today because your lives in some fashion have been touched with a brain tumor, either yourself or a loved one with that. And I'd like to say that we are committed to the treatment of brain tumors. We know that you're committed. And I'd just like to say that when you meet Dr. Toms later, you'll all feel that he should be committed with it. Oh. Oh, sorry, it is recorded. Can we erase that? And I think that it's a lot of courage for everyone here today. You know, I always say to patients, what do you want to know? What don't you want to know? And patients want to know different aspects of their care at different points. And I think it takes a lot of courage to face the reality of what we have. And some of you may learn some other things today, and I think it does take a lot of courage to come here and face the fears and the realization, but also the hope that's there and new things that are in the offering. I'd like to point out that I'm very satisfied with what I do. I love this slide. I don't know how well you can see this, but and I don't know if anybody in here is responsible for this, but I saw a patient back in '98. There it is there. And I like to tell the story that I jokingly told the patient I'd give them my 2 cents worth, and their insurance company took me seriously because the check is made out for 2 cents. And I love this down here. See a separate explanation for payment. I think I threw that away because I'd love to read how they explain sending me a check for 2 cents. But just to let you know, I'm very well paid with that. This is Stonehenge in England. Oh, I didn't tell you at the start, the rose that was on the first picture is a picture that my son took a number of years ago. He also took this picture, and I like to incorporate his photography into my talks. But just as there's a lot of mystery underlying Stonehenge, obviously a lot of mystery with brain tumors, and we hope to elucidate and work through some of these a little bit. So this isn't how I got here. This is how you guys got here today. And for a lot of you, you may have had some type of a seizure or other neurologic event that brought you here today. You may have been placed on steroids, Decadron, dexamethasone. You may be on an anti-seizure medication. I know we spend a lot of time with patients discussing the various anti-seizure medications. You may be on Dilantin, you may be on Keppra, Tegretol, one of the other medications. And you've probably had some type of an imaging study completed, either a CT or an MRI scan. And for most of the patients here have probably had a surgical procedure, although some will not have at this point, and a diagnosis has been given. And I always love this, and actually I'm going to concentrate a lot of my talk today on sort of this bottom statement here, that everybody will give you advice, and I hear this a lot, and I think that when your relatives and friends and people you don't know that see your scar and your hair loss from your radiation give you advice, just smile at them and nod your head with that. But the computer seems to have all the answers, even if we don't. You'll go to your computer and they will have all the answers for you. And we're going to discuss that a bit today. A couple of things in terms of definition of terms. So primary brain tumors are tumors that arise within the brain itself. And metastatic tumors, on the other hand, are tumors that go to the brain from a different location. So breast cancer that goes to the brain, metastatic. Lung that goes to the brain, metastatic. The most common primary brain tumor of adults that we work with is a tumor called a glioblastoma, and we'll discuss that a little bit as well. Today's talk, I think, will focus a little bit more on the primary brain tumors, but certainly a lot of the things will be discussed today are applicable to you if you don't have a primary tumor, if you have a metastatic tumor with that. In terms of terms, I like, of the primary brain tumors, a glioma is sort of a broad term. It's like saying you have a car there's different types of CARs. And the most common type of glioma is a tumor called an astrocytoma. And astrocytomas are tumors that look like astrocytes, so we trickingly call them astrocytomas. And oligodendrogliomas are tumors that look like oligodendrocytes and have been termed oligodendrogliomas. Whether or not they actually come from an oligodendrocyte is a separate argument. But they're really named based on what they look like underneath the microscope. And meningiomas, another very large group of tumors that we look after, are tumors that arise from the coverings of the brain or the outside of the brain. And they mostly cause problems by pushing into the brain with that. I put this up here because this is something that we do on patients all the time, and you may or may not be aware of it. But when we see patients in the office, we actually do a KPS score on patients all the time, or a Karnofsky performance score. And if patients are going to go on a clinical trial or not, they generally need a Karnofsky performance score of at least 60 on this scale. It's a little bit of a rough scale because there's no sort of in-between. You know, it sort of goes in tens. There's no 15 or 25 or that type of thing. So sometimes a little hard. But in general, for patients to go on a clinical trial, they need to have a KPS of at least 60, which means that patients require some assistance but basically can sort of look after themselves. So if your score is below that, you may not be able to go on a clinical trial simply for that basis at that point. If your score improved, then you might be able to go on a clinical trial down the road. If we look at the incidence of primary brain tumors, or the tumors that start in the brain, it's about 17,000 new cases a year of that. And it's actually, Dr. Hilden will talk to you a little bit, it's actually in adults it represents a small percentage of tumors, less than 2%. In pediatric population, a much greater percentage of their tumors. And I think this sort of goes to where the funding and the money is for looking after brain tumor patients. If you have an incidence of tumor that represents less than 2%, and even though these numbers may sound like a lot of numbers, if you're looking at drug companies develop new drugs and that type of thing, obviously they're looking for where they can get their bang for the buck. And some of the other people who will talk to you today are looking at bringing new drugs forward that we're trying to develop in the lab ourselves. We don't necessarily have to count on someone else quite as much with that. If we look at the grading and with the gliomas themselves, most of the tumors we grade somehow. No matter what we call your tumor, there's some sort of a grading system. There's not always a single grading system, but there's a grading system out there for most of the tumors with that. And you know, again, it's important more so for putting patients into clinical trials, what the grade of their tumor is or not with these types of tumors. And I really put this up not to confuse you because I think some people will be talking about this later. If you look at the development of a glioblastoma and you start up here, you can sort of get to a GBM one of two ways. And you start with a normal cell. And the point that I want to make here is that there's lots of things here as you sort of go on both sides that can be deleted, you know, meaning something can get absent or it can be overexpressed or you can see too much of it. And some of the other talks that will come up will discuss some treatments that are aimed at working at trying to target treatment. What do we know that's abnormal? Can we fix it? Can't we fix it? We may not necessarily understand why something becomes abnormal, but if we understand that there is something that shouldn't be there, can we treat it or can we target something that's overexpressed with that? So a lot of the work that's going on nowadays is to try and find some of these alterations and to treat them. And I'll just put this up as well that we have to continue to do a lot of hard work, and it's one of the reasons that there's so much intensive lab work going on, is that the glioblastoma tumor can be a very hard tumor to treat with that. And mostly because there's a lot of cells that are there. And even if you surgically go in and remove the tumor that's there and you radiate it and you give patients chemotherapy, if you have one cell that's capable of division, that cell itself can self-replicate itself. And we constantly need to look at better treatments and move forward with research with that. I think that in terms of medical therapy for patients, a lot of patients, and I'm sure some of the people out here right now are on steroids. If you're on steroids, you should always be asking yourself, do I need to stay on the dose of steroids that I'm on? Maybe I need to talk to my doctor and say maybe I should go up, maybe I should go down. But if your steroids are decreased and you're having a problem, make sure you let somebody know. Or if you've been on a dose for some time and you're doing really well, let somebody know. Because we would like to decrease the steroids if we can. The steroids generally decrease swelling in the brain with that. And I'm always after everybody in the medical community, if we can develop a drug that will do the good things of steroids, without the bad things, we'd improve the quality of our patients' lives 100-fold. And we talk to patients a lot about anticonvulsants or anti-seizure medications. And generally, we tell patients that if they have a brain tumor and they've never had a seizure, the data hasn't really supported leaving patients on anti-seizure medication. And I know there's a number of patients out here today that we've taken off of anti-seizure medicines. And we often have a discussion with you about different types of seizure medications, drugs that are metabolized in the liver versus drugs that aren't metabolized in the liver. And we're always interested in trying to decrease the interactions that we have. If we look at the treatments, as mentioned, Dr. Toms will talk to you about surgery today and some of the new things that are going on there. Dr. Crownover will discuss radiation therapy. Dr. Peerboom usually gives a chemotherapy talk, and I think there'll be a little bit of that today. I'm actually not going to talk that much at all about chemotherapy because I'm going to discuss something else that I hear a lot of today. And I think that from the lab, you'll hear some talks on new treatment and translational work, or taking work from the bench or the laboratory to the clinic. Some exciting stuff there. And I only put this up to show you one example of what's happened over the years. If we look at patients that have oligodendrogliomas with that, we can, and if you have one of these tumors, we've talked to you about this quite a bit, but you can see that a lot of the patients that have oligodendrogliomas may have loss of a certain chromosome called 1p. And 5 years ago, we didn't know the relationship of this or the significance of it or how it might influence how we would treat a patient with chemotherapy first, with radiation first. But now we routinely do these types of testing on patients. We check to see if chromosome 1 is there or not there, and we sit down and discuss with patients how that may or may not affect their treatment. We're starting, and I think Dr. Vogelbaum will discuss a little bit about EGFR, and I won't go into that because I think he will. But you can see there's a lot of other things in here that either say they're overexpressed or not, and I think as time goes on, you'll see more treatments directed at specific abnormalities within a tumor itself. I won't go through here. I showed this last year, and I know Dr. Vogelbaum liked it, so I thought I'd show it again, my conspiracy theory, because I hear it all the time and just even heard it again last week. I like to say that with Kennedy, you know, there's a conspiracy theory. Everybody thinks he's still alive. Roswell, there's a conspiracy theory. I know the aliens are out there. I probably should have put Elvis up there with it as well. But brain tumors, you know, there's a conspiracy theory. I make light of it a little bit, but, you know, patients to some extent do believe that there's a cure out there that's not being given to them when they meet physicians in the clinic. And that's really what I would like to address today in the talk that I give you, and I will go through some of these. I know you can't see this very well, but it says the internet accelerates spread of bogus cancer cure. And I do get patients that will bring me internet information on this. Some of it I know, some of it I don't know. But if you read through this one, it talks about a treatment at the Holistic Institute in Tijuana, Mexico. And essentially, they say that they can cure their tumor. It's not just brain tumors, it's any type of cancer. And they have this bioresonance machine that you can just sort of set the dial like your radio, and you can cure over 240 different types of cancer. The kicker is that it does cost you, my eyes aren't so good anymore, I think it's about $14,000 US to do it. But the advantage is that if you don't have that kind of money, you can actually train your loved one for $100 a day for 14 sessions that can understand how to turn the knob, and they can cure you with that. And my advice is that you're probably better off buying a bottle of tequila than going to Tijuana to do this type of a treatment. But you see a lot of this. The other thing is that Hope cancer. Judah Folkman is really a legendary figure in the field of anti-angiogenesis, or development of new blood vessels, or in terms of blood vessel growth with brain tumors. And the theory is very simple, that if tumors are going to grow, they need a vascular supply so they can continue to grow. So they've done development of a lot of anti-angiogenesis drugs, or drugs that can inhibit the growth of new blood vessels with that. And he had done some mouse experiments, as I'm sure some of the other people will discuss with you a little bit today, where they found some nice findings with these types of drugs, but it had never been looked at in a single human. And of course, it shows up on the front page of the news, we can cure these tumors, and then they have to attract it, and everybody gets excited, and they phone everybody, and they say, I want that. And these things had never been looked at in a single human when this first came out. So you have to be a little careful when you read things in the newspaper exactly what's gone on or not. We're happy to try and answer the questions for you, but the press is ready for something big, and they're ready to jump and can cause some problems. So I'm going to discuss a little bit questionable cancer therapies, and you can decide if they're questionable or not. But the American Cancer Society has defined questionable methods as lifestyle practices, clinical tests, or therapeutic modalities that are promoted for the general use for prevention, diagnosis, or treatment of cancer, which are on the basis of careful review by scientists and clinicians deemed to have no real value. Now, I'm sure that some of you out there will be using or have used some of the things I'll say today. Don't be discouraged if you have or have not, but I'm sure that some have. So the typical misrepresentations that are given is, number one, the patient really never had cancer and they're promoted as having cancer. Number two, the cancer was really cured or put into remission by a proven therapy, so they did standard chemo or radiation, and then they did this other thing, and it's really the late effects of that treatment that did it. The cancer is really progressing but is presented as cured or slowed, which sounds clearly ethically wrong. Number four, the patient has died as a result of the cancer but is represented as cured, certainly a misrepresentation. I'll show you some examples of this. Or the patient has a spontaneous remission, which is rare but can happen, or they have a very slow-growing tumor and they're presented as something other than that. And the misinformation that's out there is, number one, that cancer is a symptom, not a disease. Sort of like the Middle Ages, that you get sick because you did something bad and you need a penance and you need to drive it out of your body with that type of thing. And symptoms are caused simply by diet, stress, or environment, and by changing all of those things, suddenly you're going to be cured. I think that these things are all important. I think that diet is important. I think that stress is important. I think the environment's important. But the belief that those alone will cure your problem, I think, are misrepresented. That proper fitness, nutrition, and mental attitude allow biologic and mental defense against cancer with that. And again, I think that we all need a positive attitude towards these things, but they're sort of pushed over to the edge. And that conventional therapy is the devil, that it weakens your body's reserves and it shouldn't be done. So a few examples. And so Brzezinski, and I really bring up the things that I get asked all the time. So Brzezinski has his clinic down in Texas, and he has a treatment that is said to normalize cancer cells. And the journal, the JAMA in '92, published an article where they sort of looked at the cases that they could that he provided to them, and they did not find that the treatment that he had actually normalized cancer cells. And then in '88, Sally Jesse Raphael featured 4 miracle patients with cancer that had been cured. So they were presented on there, everybody was cured, everybody's jumping up and down. And then in 1992, Inside Edition reported that 2 of those 4 patients had died and a third had recurrence with that. CanCell, probably most of you probably know it as Protocell, is what I hear it mostly as. And again, it's thought to cure cancer by lowering the voltage of the cell structure by 20% and causing cancer cells to be digested and being replaced by normal cells. And the makers claim that it can't be analyzed, which is certainly that'd be in your best interest. Well, you can't analyze it because it's got some, it varies with atmosphere and vibrations and keeps changing its energy. So I'd be a little suspicious of something that someone says you can't really analyze it there. But lab tests were done by the National Cancer Institute in the late 80s and up until the 90s, and they really found no evidence that CanCell was effective against cancer. And I'm not talking just brain tumors, I'm talking all types of cancer. I'm not exactly sure how to pronounce his name. I like to pronounce it Hoxsey. Because I think that's probably more what this is. But he promoted a herbal treatment consisting of an external paste or a powder and a tonic that was taken orally, and he got it from his great-grandfather in the 1840s. And it just reminds me of an old episode of Gunsmoke, some guy coming by in his wagon selling elixir out of the snake oil out of the back of that. But he treated patients for about 30 years or so, and interestingly that you'll see with a number of these that he developed prostate cancer in the 60s, and he underwent conventional surgery after his elixir failed to actually cure his cancer. And I always find it interesting with people that have cures that develop cancer, and you'll see some other examples of this. Hydrazine sulfate was promoted in the 70s really to treat weight loss and other problems associated with cancer. And the NCI did 3 clinical trials with a fair number of patients in it, mostly with lung cancer. And they found that patients treated were more likely to have nerve damage, and their quality of life was worse if they took this medicine than if they did not. And in December of 2000, the Annals of Internal Medicine published a report of a 55-year-old gentleman with cancer who self-treated himself for 4 years and got into liver damage and renal damage with that. You'll hear a lot about immuno-augmentative therapies, or trying to change your immune system with that. And it was developed by a gentleman by the name of Burton, who claim that you can stimulate the immune system. And a lot of this stuff makes a lot of sense. I mean, I hear it and you go, yeah, it makes sense to improve your immune system. And he would inject patients with various protein extracts. And our friends at 60 Minutes in 1980s reported a cancer cure with the IAT. But, they sort of shoot their show and then it shows sometime later. And actually, by the time the show was going to be aired, the guy had actually died with that. And 60 Minutes refused to divulge the information that the patient had actually died with that. Laetrile came out in the 70s and 80s, and it's a trade name for a synthetic relative from apricot pits and apple seeds and bitter almonds, and was called vitamin B17 with that. So I guess sort of coming off, everybody knows the B vitamin, so let's give it a name that would sound familiar to people. And they claim that cancer is a vitamin deficiency, and that if you take this B17, you can cure it. And it was first used in the 50s, and it's been tested in at least 20 animal models, and it's really not been shown to have any benefit. And Mayo Clinic 20 years ago did a clinical trial with 178 patients, and they did not find one cure or stabilization with its use. Macrobiotics, again, I see patients that are on macrobiotic diets, and macrobiotics is really more a quasi-religion than it is a diet per se, because it's not just that you take this diet, it's sort of the whole yin-yang and lifestyle change, and you can't have certain things in your house and those sorts of things. And a person by the name of Kushi here is really the leader of this movement, and they claim that cancer is largely due to improper diet. You're not thinking properly. It's your way of life. So it's really your fault. And the great thing about that is if they can't cure you, it's your fault. So you're not thinking well enough and doing well enough and giving enough money. But interestingly, and again, in 2001, his wife died of cervical cancer. So I get very suspicious when people that can cure cancer can't cure their loved one. Maybe he didn't love his wife that much. I don't know. Not that could happen. Shark cartilage, again, we hear a lot about shark cartilage, and powdered shark cartilage is reported to claim a protein that inhibits the growth of new blood vessels with that. And, one interesting thing that was brought up at a meeting that we had the other day is that, anti-angiogenesis can be pretty tricky, because how do we get a lot of the chemotherapy to the tumor? We get it by, it going into the bloodstream and gets to the tumor through the bloodstream. So if we get rid of the blood vessels at the tumor, maybe we're also going to affect our ability to get chemotherapy or drugs to the tumor. And if we get rid of the blood vessels that are there, we're probably going to decrease the amount of oxygen that's at a tumor. Tumors like to be in a hypoxic or a low oxygen atmosphere. So, we have to be a little bit careful about these therapies as well. So the problem with shark cartilage is that it's a protein. So when you take it into your stomach, it goes into an acid pH, and it probably denaturizes the protein when it's in your stomach, and it's probably never really absorbed into your system. And if you took this protein into your system, you'd probably develop a bad immune reaction to it, and that wouldn't be so good either with that. And again, our friends on 60 Minutes in 93 had a show where they had the author on it, and he wrote this book called Sharks Don't Get Cancer. And I've been told actually that sharks do get cancer, so I'm told, number one, that that's wrong. But they highlighted a Cuban study of 29 terminal patients who received shark cartilage and were improved. The NCI reviewed this data. The National Cancer Institute reviewed the data, and they found no benefit at all from this. And ASCO, which is a large cancer organization in the U.S. in 97, reported on 58 cancer patients with a life expectancy of at least 12 weeks who were given oral treatment with shark cartilage, and there was not a single complete or partial remission of the tumor in these patients with it. So unfortunately, when we look at these things in clinical trial, they don't seem to hold up quite as well. Vitamin C, I'm just about at the end here. Vitamin C, Linus Pauling, who a lot of you probably know is sort of the father of vitamin C back 30 years ago, and he really said, you have taken enough vitamin C when you have diarrhea. That's sort of how you know, because it irritates your gastrointestinal tract so bad. But back in the late 70s, he reported a group of 100 terminal cancer patients treated with 10 grams of vitamin C that survived 3 to 4 times longer than expected. So Mayo Clinic did a clinical trial, 3 actually blinded trials in almost 400 patients with advanced cancer where they gave the same dose of medication, and again, shockingly, they found no difference. And also interesting is that Pauling and his wife both died of cancer with it. So at the clinic, what are we doing? Well, I think that, I want patients to let us know what they're taking, because the only way we're going to understand these things is to know what they're taking. We'd rather understand and go through. We certainly don't have all the answers for the things that are out there, but we're happy to hear that what you're taking. We're a member of a number of consortiums that are doing large clinical trials to try and answer some of these questions. We're a member of a group called RTOG, which is a radiation therapy oncology group that does large phase 3 clinical trials in brain tumor patients. We're a member of SWOG, the Southwest Oncology Group, that again does large clinical trials, mostly chemotherapy-based. We're a member of NABIT, and we had a NABIT meeting the last couple of days, which is new approaches to brain tumor treatment, where we do, or therapy, where we do phase 1 and phase 2 clinical trials in medications that come from either industry or the National Cancer Institute to try and look for new medications. We're a member of ACOSOG, which is a neurosurgery group that looks at surgical trials for brain tumor patients. We're a member of a blood-brain barrier consortium where we look at giving some chemotherapy through different routes. And we do a lot of industry and pharmaceutical types of clinical trials with that, to try and answer some of the questions in a scientific manner that maybe if we're just sort of taking something at the drugstore, we can't answer per se. So I know I didn't really go into chemotherapy issues today, but I think that all of you have had these things discussed before, and I thought that this might be a little bit more interest to patients, because I think that they're certainly doing this. So I think we're going to save the questions until the end. So the next speaker that's going to come up is Dr. Vogelbaum, and he's going to tell you the exciting things that he's doing in the lab and how he's actually taken things from the laboratory to the clinic, and I think that it's very exciting, and Mike should certainly be commended for doing that.